Hello, good afternoon or good morning, depending on where you are. Welcome to the JFNA webinar on supporting family caregivers of older adults with dementia and a history of trauma, unique challenges and trauma-informed approaches. Welcome to our subgrantees, the aging services providers, esteemed speakers, and 644 people who registered to join us today. Thank you. I'm Shelley Rude-Wernick, the Managing Director of the Jewish Federations of North America's Center on Aging and Trauma, a project of our Holocaust Survivor Initiative. The center is pleased to serve as a resource center and funder of services to Holocaust survivors, other diverse older adults with a history of trauma, and their family caregivers. Over the years, we've learned from the experiences of Holocaust survivors that trauma is at the root of many current responses to situations and environments. This presents unique challenges for family caregivers of older adults with a history of trauma. Couple this with people who have dementia or Alzheimer's, and the challenges become very complicated. We want to make sure that family caregivers have tools and resources on how to help their loved ones. After overseeing the funding of hundreds of person-centered trauma-informed projects in 21 states, speaking with more than 24 leaders of minority and prominent aging groups, and sharing our work at national conferences, we've learned that the person-centered trauma-informed approach can be very helpful to family caregivers. Person-centered trauma-informed care is a phrase that many of you may be familiar with. It's a holistic approach to service provision that promotes the dignity and empowerment of trauma survivors and incorporates knowledge about the impacts of trauma into organizational programs and policies. We're always looking to connect with service providers and funders and share what we've learned about the PCTI approach. So please reach out if you want to follow up after this webinar. I'm now pleased to introduce Dr. Barbara Bedney, Director of Research and Evaluation at the Center on Aging and Trauma, to lead our webinar and introduce our expert speakers. Thank you.
Thank you, Shelley. It is my great pleasure and honor to introduce our speakers and our topic for the day, supporting family caregivers of older adults with dementia and a history of trauma. According to National Alliance for Caregiving and AARP recent report, of the 42 million family caregivers caring for somebody over the age of 50, they currently estimate that about 28% are caring for somebody with dementia or Alzheimer's related illness. While many of these family caregivers can find their caregiving to be rewarding, we also know that it can be a challenging experience. We know from the research that there can be some negative consequences associated with caregiving, negative consequences on physical well-being, on social health, emotional health, even on cognitive health and financial health and well-being as well. Now, if you layer that, as Shelley said, on top of the issue of trauma and family caregiving for somebody who has dementia and a history of trauma, and a family caregiver trying to maybe avoid trauma triggers or try to avoid re-traumatizing their loved one, who might not be able to understand what's happening or be able to express it. Again, as Shelley said, that adds this extra layer of complication, which can really be overwhelming for family caregivers. And that's what we're here to talk about today. We know that the right information, the right programs can really go a long way to help those family caregivers in that situation. And that's what we're here to talk about. So next slide, please. Our objectives, as you can imagine, are pretty straightforward. We want to talk about the updates and trends about the relationship with dementia and trauma. We want to increase awareness about some of the unique anxieties, fears, challenges associated with caring for an older adult who has dementia and a history of trauma. And of course, we want to be able to share tips and strategies for providing the best level of care and the best programs in a person-centered, trauma-informed way to these vulnerable caregiving populations. I'm going to go briefly and introduce our speakers. We'll give each of them about 30 minutes to give their presentations, which should leave us some time for questions and discussion at the end. What we'd like, if you could just put the questions in the Q&A portion, we will try to get to them, try to get to as many of them as we can at the end of our session. So thank you very much. Briefly, I just want to go over our speakers. They are amazing. If we could go to the next slide. Jennifer Reeder is the Director of Education and Social Services for the Alzheimer's Foundation of America. This includes overseeing their national toll-free helpline staffed by licensed social workers, as well as community class programs, all instructed by various therapists and educators. Our second speaker will be Andrea Korsunski. Andrea is the Director of Seniors at Home Center for Dementia Care. That's a program that specializes in supporting people experiencing Alzheimer's or dementia, as well as providing real practical and emotional support for their families. Andrea has 17 years working with people with dementia. So as you can see, we have exactly the right people for this topic and for this webinar. Please join me in welcoming them and thanking them for participating and joining us here today. And with that, Jennifer, I will turn it over to you.
Oh, great, great. Thank you so much for that warm introduction. I appreciate it. And thank you so much to the Center on Aging and Trauma and also the Jewish Federation for this amazing opportunity to speak with all of you. So if you could go to the next slide. So the presentation I'll be providing is the bidirectional relationship between PTSD and dementia. So if you go to the next slide. So these are the objectives for the presentation. So I'm going to be sharing with all of you ways you can develop a foundational understanding of dementia and trauma. And then I'm also going to be sharing with you explaining what chronic stress and trauma can do to the brain, because it's important to know that, because that is how the brain can then become more vulnerable to dementia, which causes that bidirectional relationship. And then I'm going to be identifying the effects of untreated psychological trauma among older adults with dementia. So if you can go to the next slide. So first and foremost, what is dementia? So dementia is a general term for any disease that causes a change in memory or thinking skills severe enough to impair a person's daily functioning. Now, I'll share a little bit more in a few minutes about what exactly that means. But so the most types of dementia cause a gradual worsening of symptoms over the course of years due to progressive damage to nerve cells in the brain caused by the underlying disease process called neurodegeneration. And these neurodegenerative diseases, they lead to abnormal protein buildups in the brain. Now, where these abnormal protein buildups occur in the brain and where the damage occurs in the brain, it greatly depends on what type of dementia someone has. So for instance, frontotemporal dementia, that typically affects the frontal and temporal lobes of the brain that can impair someone's judgment and also social behaviors. And then dementia with Lewy bodies, that affects the brain cortex or the outer layer of the brain and the midbrain as well. And dementia with Lewy bodies is actually the most misdiagnosed dementia type because initially it can look like sometimes there can be rigidity or resting tremors. So somebody might receive a diagnosis of Parkinson's disease, let's say, or Parkinson's dementia. Or Alzheimer's disease. So somebody may show cognitive impairments or memory issues that can lead to a diagnosis of Alzheimer's disease. But if someone is diagnosed with Alzheimer's disease, that's usually because the hippocampus is being affected by the disease. That's usually the first place in the brain that Alzheimer's disease affects the brain. But as you can see here, impact in any type of dementia, you'll see the impact in the following areas. So memory, judgment, motor skills, communication, and mood. So you can go to the next slide. So, and you'll just have to keep clicking it. There you go. That's perfect. Thank you. So, so when we're talking about Alzheimer's disease and memory loss, it's really important to also kind of consider why memory loss happens and other reasons why it may happen, because it's not always going to be Alzheimer's disease. So there are a variety of reasons why memory loss may occur, and it may be because a normal age-related issue. So, if somebody's having troubles with like misplacing keys, forgetting a name, those sort of like normal age-related reasons why there's some memory loss. But then it could also be because of mild cognitive impairment too. So mild cognitive impairment, that's not always going to lead to Alzheimer's disease. Sometimes there could be health conditions that are causing the mild cognitive impairment. So, and this is why it's always important to go to a doctor, because there may be reasons that could be improved from either medication or diet or something like that. So another reason would be health conditions such as B12 deficiency, hypothyroidism, chronic alcohol or drug misuse, brain tumors or delirium. And then also dementia. So dementia could be another reason why someone is experiencing memory loss. And that will usually be Alzheimer's disease because, as I mentioned, that's where Alzheimer's disease first tends to go, is the hippocampus. So it is really important to consult a physician if anyone notices any of the following. So memory loss, confusion around time or place or person, familiar routines become a challenge, such as chores or work-related activities, or executive functioning skills, like money management and problem solving. So I know I keep mentioning the hippocampus, and you'll hear me continue to mention it during this presentation. So, and I just want you all to remember this part of it, that the Alzheimer's disease does typically first affect that part of the brain. So now I'm going to be shifting a little bit to trauma and how chronic stress and trauma affects the brain so that you can see these parallel ways in which it happens. And as I keep mentioning, the bi-directional relationship. So you can go to the next slide. So I first want to share a little bit about emotional memory. So emotional memory are highly emotional events that are preserved in memory. So this typically happens, if somebody has any type of especially negative emotional memory, and I'll share that a little bit too. If it was seriously impacts a person, they may not remember all of the details of the event, but they will remember the emotional experience that they had. So that's what emotional memory is. Now, studies are suggesting that individuals with Alzheimer's may actually retain memory longer from emotionally negative experiences, despite the progression of the disease. So there was a report in the National Institute of Health by Okada and Matsu. And they were speaking of these two different studies that occurred. So there was a study on the survivors of the 1995 Hashinawaji earthquake. And what they found with the survivors who had Alzheimer's disease was that even after 6 weeks, after 10 weeks, months later, the survivors with Alzheimer's disease, they were still able to remember the earthquake, but they couldn't remember any of the details of the earthquake. And then the same researchers, they also discussed two individuals who were studied during a study, who were followed by the researchers for many, many years. And these two individuals, their Alzheimer's disease continued to progress during these years. And unfortunately, they had severe short-term memory loss, which continued to affect just their daily functioning. But both of these individuals, they both lost loved ones. And what the researchers found was that they were able to remember this emotional experience of losing their loved one after days, after weeks, after months, and even after years. They were still able to remember that they had lost their loved one. They couldn't remember the details. They couldn't remember how the person had died or the funeral services, just the emotional experience that they had of losing their loved one. So what's important, I think, to consider when you are supporting someone who has Alzheimer's disease when it comes to emotional memory are a couple of things. So one is that, if you thinking about practical terms, if someone with Alzheimer's disease is watching the news, let's say, and there are a lot of negative stories going on in the news, that may build anxiety and fear inside the person. So later on in the evening, when the person is trying to go to sleep, they still may be holding on to that fear and anxiety of watching the news, but not remember exactly why they're feeling that way. And then, so it's really important to think about the environment. Environment matters for the person. And then there's also important, I think, to understand too, that when we're seeing someone reacting all of a sudden to something that we can't see or understand, they may be in distress due to an emotional memory. Now, what was unfortunate with the this research was that they found that emotional arousal caused by extreme negative events, it had to be negative events. Unfortunately, it wasn't positive events. These individuals may have had amazing experiences with their family, but didn't remember that, but they would remember the negative experiences that they had. So, so yeah, I think that that's important to just walk away with is environment matters and what it is that you expose the person to and share with the person. They may not remember those details, but they are going to hold on to the emotional experience that they had during that time. You can go to the next slide. So now with all of that, I'm going to share with you the impact of stressful events on brain health. So what does chronic stress, what does trauma do to the brain? So they're finding that repeated stress can have a huge impact on the brain, leading to physical and psychological issues. So what they're seeing is that there are changes in the amygdala, which is the emotional response center, the prefrontal cortex, which is responsible for executive functioning, higher levels of thinking and reasoning, and then also the hippocampus, which is responsible for memory and learning. And so it makes sense if you think about someone who is experiencing chronic stress, that they have a difficult time responding appropriately to a situation. They may become overly agitated, overly upset about something because their prefrontal cortex, that is their level of reasoning, that's being affected, as well as their emotional response center. And another reason why victims of trauma, survivors of trauma, may struggle to remember the trauma or remember details of it because their hippocampus is being affected. So they also found some other things too. They found that repeated stress triggers persistent inflammation in the body. So chronic inflammation leads to diabetes and heart disease. Now, those are both risk factors of Alzheimer's disease and vascular dementia. And dementia also affects the blood-brain barrier in the brain. And what they found is that the blood-brain barrier under chronic stress actually weakens the blood-brain barrier and can become leaky, allowing inflammatory proteins into the brain. And as I mentioned, dementia is due to abnormal protein buildups. And they also found too that chronic stress affects hormones in the brain, including cortisol. And high and prolonged levels of cortisol have been associated with mood disorders and shrinkage of the hippocampus, going back to Alzheimer's disease. So this is why we're seeing how someone who may have experienced chronic stress and how it affects the brain is more vulnerable than to dementia, especially Alzheimer's disease. So, and I think it's interesting too. So there was a study at the University of Wisconsin in 2017, where they found that stressful life experiences age the brain. Now, for white Americans, it was 1.5 years, and for Black Americans, it was 4 years. And that is because Black Americans have 60% more stressful events on average than white Americans do. And this all leads to their findings that Black Americans are 2 times more likely to develop Alzheimer's disease, and Latinos, Latinx, Hispanics are 1.5 times more likely. And this is all due to racial trauma, healthcare disparities, educational disparities, and environmental causes as well. So what we're seeing is that it is imperative to think about brain health from birth. I think historically it has always been thinking about the brain when someone has Alzheimer's disease. This is when we need to pay attention. It's from birth. So you can go ahead to the next slide. So, and this is, so with traumatic events, so, you know, as I'm saying here is that we're seeing how this is all affecting the brain. And so what exactly is a traumatic event versus a chronic stress? So a traumatic event is a sudden, unexpected, potentially life-threatening event over which the person has no control or witness to the event. So it could be an actual or threatened death. It could be a serious injury. It could be a threat to physical integrity. But what they're seeing is that traumatic events affect nearly 39% of the US population within their lifetime. So you can go to the next slide. There you go. So, so when someone experiences trauma, a traumatic event occurs and it can affect the three domains of a person's that's associated with good physical health and mental health. So these are the areas that are disrupted. I think it's really helpful to know what areas are disrupted in a person's life so that when you are either treating a person, treating the trauma, or you are just supporting someone who has experienced trauma, these are the areas that you can focus on. So first is reasonable mastery. So that's the ability to shape one's environment to meet their own needs. So that's being able to choose what kind of job you want to have, what kind of house you want to buy, what kind of neighborhood you want to live in. That's all reasonable mastery, having this sort of control over your life. Caring attachment to others. Affiliation with other humans that provide support, companionship, information, and sometimes assistance. So there's that level of trust that what I give for you, you will give for me, and trusting one another. And then there's a sense of meaningful purpose in life too. So the reasons or values that motivate a person to become engaged in the world each day. So as you can imagine, this is how someone who has experienced a trauma that they feel that they have no control over their life. They do not know how they can trust anyone. And what is their sense of purpose in the world, in society, if they feel that they can't trust their world and society? So you can go to the next slide. So, and then these are what the symptoms of trauma look like. So someone may experience physical symptoms such as hypervigilance. Hypervigilance is an attempt to restore sense of safety, anticipating or seeing everything as a potential threat, and then acting accordingly. So this is where you hear about like the flight, fright, or freeze mode that someone is in. You see exaggerated startled response. So this is where they're trying to constantly figure out how they can be safe. And then there's also intrusive, painful recollections of the events. So that could be daydreams, nightmares, flashbacks. And what's interesting about flashbacks is that people experience flashbacks, they come from the hippocampus. So adrenal glands release adrenaline, which has been shown to help encode memories to the hippocampus more intensely. So yet again, how trauma is affecting the brain in areas where dementia tends to first go. And then there's avoidance symptoms as well. So avoiding places and thoughts associated with violent acts and withdrawal from other general life events. So you can go to the next slide. So what happens when trauma is untreated? When trauma does not subside, long-lasting psychological disorders develop. As we've seen, PTSD can last a lifetime. And psychological trauma is frequently untreated, especially in older adults. I think that's unfortunately because I think people for a long time haven't really seen the benefits of mental health, and there's always been a stigma around mental illness. And when you think about war veterans so often that sort of culture and community is all about staying strong, being strong, never saying you need help or support at all. And this is why I think there are a lot of war veterans who develop PTSD that's untreated and are therefore more at risk of developing dementia later in life. And the effects can manifest through substance abuse, suicide, panic attacks, depression, and generalized anxiety. So this is why it is so important. And we're always trying to raise awareness about receiving support and help when it comes to PTSD, and also receiving an early diagnosis of Alzheimer's disease if that's what's happening for you, because then you can take more power and feel more empowered over your health and over your life. So you can go to the next slide. So, and this is what can happen. People will develop post-traumatic stress disorder. Not always, but this is one of the consequences of a traumatic event and not receiving that support. So post-traumatic stress disorder, it's expected that 7 to 8% of the US population will develop PTSD. And about 8 million people in the US reportedly have PTSD in a given year. Now, what's interesting is that men are actually at a higher risk of developing exposure to traumatic events, while women are at a higher rate of developing PTSD. I think I found that the main reason for that, I think, is unfortunately because women tend to experience sexual assault more often than men do. And sexual assault, it has a greater chance of leading to post-traumatic stress disorder. So you can go to the next slide. So bringing all of this together, post-traumatic stress and dementia. So links have been found between PTSD and dementia among veterans, war refugees, non-combat related traumatic experiences, even after taking out other factors that could influence PTSD and dementia. So that includes gender, age, physical health, psychiatric conditions, and drug and alcohol misuse as well. But what they're seeing is that the rate of being diagnosed with dementia in a person with PTSD is almost 2 times the rate of those without PTSD. So the potential reasons for this, it could be that post-traumatic stress speeds up cognitive decline in older age, which wears down the brain, making it more vulnerable to cognitive decline and dementia. Excuse me. And then also PTSD, unfortunately, tends to present with other risk factors of dementia too. So depression, social isolation, and higher alcohol intake as well. But this is why it's really important, I think, for especially primary care physicians to know what populations are more at risk of dementia, so that, and PTSD as well, so that they can ask the right kind of questions during medical office visits. But so, as it says here, recent studies have also shown that early life trauma can increase the risk of Alzheimer's disease. So we're talking about childhood trauma can even affect someone and put them at greater risk of dementia. Next slide. So what are the consequences for older adults? So what they're seeing here is that individuals who are able to manage the effects of traumatic events are unable to do so after physical and cognitive health declines. So, that means, like, if you're thinking about someone who has experienced a childhood trauma or even a midlife trauma, as I was talking about how it affects the brain, makes the brain more vulnerable to developing dementia. The person then later on, let's say they develop dementia. Dementia then starts to deteriorate the brain. So what is also deteriorating are those coping mechanisms. So a lot of the times when someone has experienced a traumatic event throughout life, they develop coping mechanisms, whether they are healthy or unhealthy coping mechanisms, they're there. And that's what gets them through every day. That's what gets them through life. Dementia sets in, deteriorates the brain, those coping mechanisms then deteriorate, which then leads to older adults re-experiencing trauma. And so this is so important to acknowledge, because when an individual with Alzheimer's has recollections of a traumatic event or experience, memories may not surface clearly, or they may intensify even as well. So someone who has short-term memory impairment or memory impairment in general, they can become extremely confused as to whether this is the past, whether this is the present. Flashbacks are very real. It can take on all of your senses. And so the reactions to these re-traumatizations can be very easily misinterpreted, resulting in restraints or unnecessary medication. And, this is why I think it's important for everyone to be educated about how traumatic events can affect an older adult who has dementia, so that if someone does suddenly have an outburst of agitation or anger or sadness, it could be connected to a flashback that they're experiencing or that emotional memory that they're experiencing. Medication, not all medications are are healthy for older adults with dementia. Psychiatric medications are not FDA approved to treat dementia psychiatric symptoms. And especially antipsychotics, those can be very, very dangerous for people to take who have dementia, especially people with dementia with Lewy bodies, because of the way that affects the brain. So that's why it's so important for us to be thinking about non-pharmaceutical interventions to support older adults who may be experiencing a re-traumatization of trauma. You can go to the next slide. So, and the thing is with diagnosing PTSD in older adults, it can be very, very tricky. As you can imagine, because it's very difficult for clinicians to mistake early symptoms of PTSD as other medical disorders. It could be side effects of medication. It could be due to the dementia that they have. So it can be really hard for an older adult to receive a diagnosis of PTSD. And even if someone was diagnosed with PTSD who has dementia, it's likely that that person is not going to be able to go through trauma-focused therapy, because trauma-focused therapy is very, very intense and can be very overwhelming. So for someone who is already struggling with the symptoms of dementia, that may be too overwhelming. So you can go to the next slide. So, I think what we're always, I'd say, recommending as best practice is really to take a person-centered approach to trauma-informed dementia care. Now, I think the question is, well, what if we don't know if they've gone through trauma? Well, taking a person-centered approach to trauma-informed dementia care, it's not going to harm the person in any way if they haven't gone through trauma. So if you have concerns that they have, taking this approach is only there to really, I think, enhance the support. Because if you look at what it is that's the overall sort of approach, and I know that our next presenter is going to be getting into this a whole lot more than I am right now, but this is just kind of what it looks like. So, being present with the individual, creating a safe space for the person, helping the person feel a sense of control wherever they possibly can. If that is with their personal needs, choosing what meal they want to eat, anything to help them feel a sense of control. And then sometimes it's about seeking beyond common interventions for dementia by assessing what the triggers are for the person. There was an article that I had read. It was from J. Scott Jansen. He was talking about trauma-informed dementia care. And there was a really interesting case that he was talking about. And I think it's kind of like a really good example of what it can look like to provide trauma-informed dementia care. So it was a gentleman who apparently was a very, very mild sort of gentleman. He didn't really talk a lot. And he had been at a residential, he'd been at a facility for, I think it was a long-term care facility where he had been there for a while. And all of a sudden, out of nowhere to the staff, he started sundowning every evening. He would get really agitated, really aggressive towards the staff. He put his fists up like he was about to defend himself, like he had to defend himself. And he was just saying lots of things that weren't really making sense. So, but some of what he was saying made it almost sound like he had been in a war of sorts. So they talked with the family, and the children said the same thing, that he was a very stoic, very quiet man. And learning more about, so they started asking questions if he had been a veteran, if he was a veteran, if he had experienced any trauma. And the son had mentioned that he had been in the Korean War, and he never talked about his experience in the war at all. But the one story that he did share was, I guess, him and his unit, they were under extreme fire from they were in the war, they were being shot at, and they were trying to cross a river, and the river was really deep and it was really cold because I guess it was wintertime, and he almost drowned. So they considered that. They considered like, okay, so he's been talking things, maybe what he's been saying are things that were coming from the war. And so then they were considering some other things too. It had just snowed outside, and it never snowed in this part of North Carolina where they were. He had just fallen recently, and pain can be a trigger to traumatic memories. And it can also be very difficult for a person with dementia to be able to share that they're experiencing pain because they may not even be able to recognize that. And he had also just started on a new medication that they were giving to him in the mornings, but may be causing drowsiness. So could be enhancing even more his inability to really tell if he was in the present or the past. So they considered all of this and they changed his medication to being in the evening time. They decided to, like, in the evening when they would give him a bath and do the bathing aspect, they would only use really warm water, not hot water, but warm water. And they would turn the temperature way up in his room to cut out any bit of cold feeling at all. And by doing this and being consistent with this, after a few weeks, the aggression, the sundowning subsided. So that's just a way for people to look outside the box. And the way they did that was partly about gathering information from the family members because the gentleman was unable to share what had happened to him and what he had been through. And then you're also wanting to build those positive emotional memories. Staff, if someone has had a negative experience with you, they'll probably have a negative emotion when they see you again. So making sure to create those positive emotional memories wherever you can, creating communal experiences, and then reassessing prescribed medications, as I mentioned in the story, and then also thinking about psychiatric medications if it's really hindering or helping the person or not. So that is pretty much my presentation. And then if you want to go to the next slide. So this is just what we offer at the Alzheimer's Foundation of America. If anyone has any questions, you can always reach out to me. You can call the main number, and I think maybe we're going to be able to share our contact information if anybody does have any questions for me or for AFA. Our national toll-free helpline is staffed by all licensed social workers. So if I'm not able to help you in that moment, hopefully they can as well. But yeah, so I guess we'll go to the next presenter. Yep, there's my information.
Awesome. Thank you so much, Jennifer. Such great information. I'm really excited to partner with the Center on Aging and Trauma with JFNA and also the Alzheimer's Foundation of America on this webinar. So I'm here to discuss person-centered trauma-informed care for people living with dementia. My name is Andrea Korsensky. I'm the director of the Center for Dementia Care at Seniors at Home. Seniors at Home is a division of Jewish Family and Children's Services. If you go to the next slide, let's see. We were founded in 1850 and we serve a really incredible and large community throughout the San Francisco Bay Area. And while we do have extensive experience in working with Holocaust survivors, we've learned so much today from Jennifer that trauma is more common than we may think, and a really important consideration in our assessment work, no matter where we are or what specific demographic we serve. We can apply best practices in person-centered trauma-informed care in all aspects of our work. So I'm so excited to share our lessons learned and best practices with you today. You will receive this presentation as well as access to a really great project that JFCS partnered with JFNA, which is access to our caregiver resource library, covering common challenges associated with caring for a person with dementia. And these publications are all rooted in that person-centered trauma-informed care approach. So please be sure to look for those documents following today's event. Next slide. Here are our learning objectives, my learning objectives today. I'll review specific skills to help you all feel confident in your ability to respond to sudden changes in mood and behavior among people living with dementia. Also to learn practical strategies in engaging and connecting with a person with dementia, and also to understand the importance and the value of person-centered trauma-informed care and applying those basic principles. Next slide. So first, let's talk about the big difference. It's very different to work with a person with dementia who has experienced trauma. Dementia attacks the very elements of cognition needed to cope and work through trauma, coping mechanisms, as Jennifer mentioned earlier. So let's think about this. Dementia affects judgment and reasoning, which is a critical coping skill needed to navigate reaching out for help when you're struggling. Also, communication. Dementia affects a person's ability to communicate, at least verbally, in an organized or linear way, a skill that would promote coping with the trauma, including the ability to communicate and process emotions associated with that trauma. Orientation, a person with dementia is often disoriented to time and to place, and this will interfere with the person's ability to reassure themselves in the moment and cope with a triggering situation or a re-traumatization. And then also insight. A person with dementia often lacks insight into current circumstances, and this ability to gain insight to the big picture or the overall circumstances is a key component of supporting a person who has experienced trauma to promote determination and survivor mentality. So what does all this mean for us in our work or in our individual experiences? Well, I think it means that we cannot use the same therapeutic interventions when working with a person with cognitive impairment. Next slide. In our work, people with behavioral disturbances, this is what I mean. So people with behavioral disturbances were often tasked with things as professionals, things like limit setting or blaming unpleasant experiences or changes on doctor's orders. And all this to gain compliance or to help explain the way things are to a person. And the problem with that is that ultimately the goal of this approach is to get a person to agree and give up their resistance. And this is you need to approach this really carefully because before applying any of these, because a person with dementia who's experienced trauma, this will result in further resistance, more behavioral disturbances, and most importantly, difficulty coping to the new circumstance and even re-traumatization. Next slide. Dementia affects the way a person can communicate, as I mentioned, and their ability to reason. So in our work, we must look for clues to help address a particularly challenging situation, like the example that Jennifer gave us. And it starts with understanding that a person may react in a counterintuitive, for lack of a better word, way. And thus any approach we use trying to convince the person and reason with them will be unsuccessful. So I have an example too recently. One of my clients who's experienced serious trauma in her life and now has dementia and has a significant history of uncontrollable anger when not in control of decisions. And those decisions can be big or small. Decisions to us on the outside feel small sometimes, but to a person with dementia, they're bigger. So I knew she needed to have smoke detectors installed, but if I offered to have them installed and tried to get her permission ahead of time, she would politely decline. Oh, I can take care of that, no problem. So using some of my detective skills and an understanding that her trauma in the past involved abandonment, lack of control, death, I chose to create a plan which helped her feel in control and avoid any of those known triggers. The smoke detectors were necessary, of course, because she's significantly hard of hearing and we had to get detectors that would dispatch the fire department directly. But there's no reasoning through this with this particular client. I would not be able to explain the necessity of having these installed by pointing out all the reasons why she's no longer capable or at risk of injury, even if she had the same goal. So trying to reason with the person and prove all the logical reasons that they must comply with your recommendations will only result in more resistance, and in this case could be uncontrollable anger. So instead, I just asked the company to call the client and schedule a courtesy appointment. They bring all the supplies and suggest installation, and the result was good. I mean, the result was that the client felt in control, safe, supported. The family and I felt better. So it's important also to talk about the family's anxieties and fears around this issue for just a moment, because they all have a history of abuse when her uncontrollable anger and abuse was directed at them. And they've all survivors of trauma. When I made the suggestion about the smoke detectors, the family was very anxious about coordinating things without involving her mother, worried that she would find out and become angry or even violent toward them. And the therapeutic approach here for the family involved just reassuring them that it needed to be done and mapping out the recommendation, but having a backup plan, right? So it's not like everything relied on that courtesy call from the company going perfectly. It was, well, we'll try it this way. And then if it doesn't work, we'll install them when she's out of the house in a discrete location throughout. So next slide. Let's get into this idea of a family a little bit more, because dementia is a disease that significantly impacts the entire family and for a prolonged period of time. I think the average is 10 to 15 years. We must consider our approach to dementia care as working with the entire family unit. This involves being aware that family members might have a history of trauma also, and we must think about what we are doing as professionals to work to accommodate this or support this. How does their trauma impact their role as family care partner? There's often a level of resistance from family members to follow through with recommendations in dementia care for several reasons, not necessarily trauma, but it could be stigma, fear, overwhelm, definitely overwhelm. Dementia care affects all aspects of a person's care needs: emotional, physical, financial. Not to mention the family has had a certain dynamic for many years. It's all they've ever known, and now it's different. If you work with a family who has a history of challenges or strain, this could be related to personality disorders, past arguments, abuse, anything really. That doesn't suddenly just go away once the parent is older, the family member is older. What we often see is a culmination of years of strain and challenges now faced with an additional challenge: dementia. It's common for people to have difficulty differentiating behaviors associated with trauma and dementia, and there might be long-standing behavioral manifestations that the family members have struggled with over the years, which then leads to accusations of denial, or blaming the person with dementia for behaving in a certain way intentionally. It's important for families to learn to see this as unintentional and respond from a place of understanding and compassion with the support of a professional team. That can get all very complicated. But whether the behavior is a result of dementia versus trauma isn't as relevant as understanding that the person who is adamant about not being told what to do or how to do it is most likely feeling scared, lost, confused, worried. And a major part of understanding dementia and trauma and responding appropriately is looking at those emotions, and they might be underlying emotions. And we can help families understand this by remaining really focused on avoiding re-traumatization for the family member and the person with dementia. So let's get into the practical approaches. Next slide, please. It's helpful for professionals to know what to look for, how to anticipate the needs of the family, and apply those best practices for both the person with dementia and the family member. Part of the person-centered approach is identifying and avoiding those known triggers. So thinking through past experiences and the current environment, Understanding also that therapeutic or compassionate lying is, and giving the family the tools they need to improve the overall quality of life. So having that perspective on quality of life, and giving them permission to do things that and change the dynamic of their communication in a way that they've never done before. Next slide. We're going to get into each one of these. So here are the basics in best practices in dementia care. Person-centered approach, focusing on validation and meeting the client where they are. Understanding that behavior is a form of communication and always responding to the emotion behind the words or the actions. And this isn't on the slide, but doing so in a way that doesn't feel like it's giving the family care partner one more thing to have to worry about. You're really giving them permission not to respond in anything reality-based. And I think that that's a really important nuance in working with families, both who have experienced trauma and who might not have overt trauma. But when you're offering these suggestions, not making it seem like it's really simple and really easy. So these are all of the basics in dementia care best practices are rooted in this trauma-informed care. And when we follow these, we're exercising this universal precaution, which Jennifer talked about earlier. So it can't do any harm to lead with a person-centered trauma-informed approach. And this will maximize the effectiveness in all of our work and our interactions with our families. Next slide. The next practical approach here is it's important to adapt how you communicate with a person with dementia. And I always like to apply Dr. G. Allen Power's non-medical definition of dementia to help illustrate why compassionate lying or therapeutic lying is important. His non-medical definition is a shift in the way a person experiences the world around them. And to me, this means that we must adapt, and we cannot expect the person with dementia to adapt to us, and to help give family members or care partners permission to try this approach. We explain that their loved one relies on them to feel safe, supported, and validated, which manages those or prevents those sudden changes in mood and behavior. And this often illustrates the importance of not sharing the full truth or the whole details of the situation. And you can usually explore the family member's experience with failed attempts at explaining too many details, which, they'll inevitably explain that it just leads to more frustration, repetition, and stress on their part. So that's a helpful tactic. And next slide. As we have discussed in a few other points today, looking to the emotion behind the action or the behavior is the key to developing the successful intervention to address it. Oftentimes, boredom can lead to these problematic changes in mood or behavior. And boredom is linked to feeling useless or without purpose or value. And we can address this by understanding that people with memory issues have increasing difficulty organizing and structuring their own time. And we can anticipate this need and adapt existing hobbies and interests into meaningful activities. So this can be more and more difficult as the disease progresses, but a good trick is to work to engage the senses. An example might be that if someone isn't able to safely cook anymore, you can prep all the ingredients, ask for help from them, assembling and turn the organized, structured task of a certain recipe or meal into a meaningful and engaging activity. Cooking engages all five senses pretty easily, but the key is to go out of your way to make sure it does. So asking yourself, how can I make this more aromatic or more colorful? There are entire courses on this topic of engagement. I just wanted to touch on it and make sure to make the connection on the importance of structuring time to managing sudden changes in mood or behavior and preventing re-traumatization or triggering experiences for both the person with dementia and their family care partner. Next slide, please. This topic here, sympathy versus empathy, really relates to a lot of what Jennifer was talking about with regard to emotional memory. I always think about the quote from Maya Angelou: people might not remember what you said or did, but they will remember how you made them feel. And it's not 100% true of people with a cognitive impairment or dementia, but for our purposes here, you know, when I work with clients, I notice that people will open up a little more when I listen and avoid trying to fix everything and having the answers to everything. Family members report similar connections when they exercise more empathy as opposed to sympathy. You know, empathy is meeting them right where they are, being a really good listener and feeling what they're feeling, which is scary for family members, but an important tool to connect authentically. Sympathy doesn't sit well with people with dementia because they already feel a lack of control, lack of connection, and sympathy doesn't promote a feeling of partnership or togetherness as much as it does superiority. So exercising more empathy than sympathy actually might be a good rule to follow in our interactions and outside of dementia care. Next slide. There's a saying I've always kind of kept with me since I was in school studying social work, and that is to be mindful not to open wounds that you can't heal. And since many of us on this call are professionals, we know the scope of our work, but it's important that if you're not going to be, it's a good reminder, if you're not going to be working with someone for an extended period of time, you must be careful not to ask too many questions directly to them about their traumatic experience, and be careful not to prompt that re-traumatization by reliving or recreating the experience or not responding in a sensitive way. So if there's anything to kind of take away from this, it's sort of that idea of anticipation of needs, and understanding that people with dementia lead with emotions, as do their family members at times. So your most successful work with a person with dementia will be when you're able to respond to that emotion behind the behavior. Well, now I want to dive into this person-centered trauma-informed care. Next slide, please. So given the statistics that we've discussed today about people who have experienced trauma and then it's likely underdiagnosed, undertreated, we're going to review here the 6 key principles from SAMHSA on trauma-informed care, but there's a twist. We're going to take a look at each of these in our work with people with dementia, but also mentioning, kind of weaving in, as I have throughout, the added element and unique anxieties of fears and barriers when working with the family care partners. You know, we've touched on considering the element of trauma among the family care partners, so it's not totally out of place, but I want you to really think about that as we jump in here. Trauma-informed care is considered, again, that universal precaution in our work, and applying this understanding will help in our work with family members. It will always benefit. So here are the 6 key principles, and we're going to go into each one of them, each of the 6 here. So next slide, please. The first one here is safety. Jennifer discussed this at the end of her presentation, and we're going to build on it a little bit. For the person living with dementia, to help reinforce safety, let's be mindful of those known triggers based on past experiences and really emphasize that anticipation of needs, because that person with dementia can't always communicate their re-traumatization or triggers. We must also be flexible, right, and accommodate those needs from the beginning. And the example that comes to mind here is like timing of appointments. Try not to schedule someone with dementia in the late afternoon, or perhaps you can go out of your way to find out the best time of day for that person to have an appointment with you. A lot of that will depend on the person's routines, and you can get that information by coordinating with the family care partner, and they'll appreciate it also. So also a huge part of supporting a feeling of safety is through nonverbal communication. And I think you probably picked up on the nuances throughout much of this presentation. Not everything has to be verbal, right? There's a lot to it that includes nonverbal communication, body language, that's closely connected with emotions, and a really important skill to have when working with these families. So what about the family care partner now? Family care partners experience trauma in many cases while caring for a person with dementia, or they may have experienced trauma at some point in their life. But we can be very intentional with our work with family care partners by specifically asking them about their own safety, giving them space to talk about what they may need in order to feel more safe in their role. I also want to talk about viewing trauma-related symptoms or behaviors as attempts to coping mechanisms. I think this is very important in our consideration here. So specifically, we often see that the family care partner just can't follow through with some of our interventions or recommendations. And we then need to adapt our approach to accommodate elements of our care plans that aren't working, right? We're making these recommendations, the family isn't really implementing them. It could be related to their own barriers or traumatic experiences or not being realistic in their individual cases. So we need to continue the conversation and figure that out. So lastly, pay attention, to the environment and any physical signs that your client or patient is feeling uncomfortable or uneasy. So working through that body language that your patient or your family member is showing you, and then work to address it through added support. Let's go to the next slide, please. Number 2 of those 6 is trustworthiness and transparency. For the person living with dementia, you must be descriptive in outlining your goals from the beginning, right? And that may evolve over time, but it's important to speak directly to them, even if they have cognitive impairment, even if they have significant cognitive impairment, and really hear their perspective. That builds the trust. We also need to model that to the family members, showing them the importance of active listening and not correcting whatever the person is inaccurately reporting, and really leading with emotion to connect with that person with cognitive impairment, and not focusing on whether or not the information they're sharing is factually correct. It's very impactful to meet with the person with dementia directly and privately, maybe, because it builds rapport and sends a message that what they're saying matters, regardless of reliability of the information. And just another reminder, we're focused on emotions. There's a theme today. For the family care partner, I think, when we're applying this, the most important element is to really ask questions and listen. Many are reluctant to share the reality of their day-to-day challenges and possible traumatic experiences. I often think, when I think about this, I think about my clients with FTD who are very disinhibited and have, pretty unpredictable behaviors. That's a lot for the family member. After you've created the safe space for the family member to share, you can build transparency and trust by hearing what they're willing to share about what they're going through, and then making appropriate recommendations to support them and making sure that they feel safe in doing so. My most successful, person-centered trauma-informed approach is probably pretty basic, asking, what's the best part of the day, and then integrating those elements into their daily routine or care plan. So for example, just a real simple, quick example, if the best part of their day is a walk, I work with the family to initiate a walk right before the kind of worst part of the day. For example, maybe right before sundowning or right in the early afternoon. Next slide, please. The third is peer support, and pretty direct, pretty obvious here. For the person living with dementia, it's important to really normalize what they are experiencing. I often say things like memory loss affects 1 in 2 people over the age of 85, and that seems to make people feel a little more at ease. I also say things that help, reassure them that there's a plan, right, to support their independence, knowing very well that independence is the most important factor for most people and the biggest barrier to being open about any cognitive changes that they're worried about. Most people, don't want to hire a caregiver, for example, but they like the idea of having a personal assistant who can help them get more done in a day. So it's all about kind of reframing. And then applying this principle for family members, I would say, it's important to connect them with others who can relate and be sure to initiate follow-up and reach out if you haven't heard from them. I find that most family members have a much higher threshold than they should before they reach out for peer support or added support from me or other professionals. Next slide, please. Number 4, collaboration and mutuality. So for the person living with dementia, reassuring them that the family is on their side, even when they have to bring up uncomfortable safety concerns or they're trying to impose, things that they don't like going to doctors and having testing done. I mean, just in general, it's important to strengthen existing support systems for that person and facilitate communication and then develop the plan. Educating the family members that the behaviors or mood fluctuations are unintentional is really important here because it gives family permission not to call that person out or try to correct the behavior or setting those limits. And then applying this principle for families means providing education and connecting with others experiencing similar roles as care partners. This can help streamline their support and ensure that they have, reliable professional support to build them up, especially for the duration of the disease process. Next slide, please. Number 5, empowerment, voice and choice, the most important for people with dementia. So we can work to bolster independence. That's the term I use in my work, and encourage autonomy in our support for them and for their family members. We can ensure that their voice and their perspective is heard by providing them an outlet to do so and training the family on how to do so in the moment. So much of trauma-informed care is creating space to listen and really just hear the client, what's going on. I think the same goes for the family member, specifically thinking about, convincing the family member that they can't do it all and they must get help, and then providing them with options that fit into their circumstances. So support groups or therapy. All right, next slide, please. Lastly here, cultural, historic, and gender issues. As professionals, we approach the family with a basic understanding on the background, collecting that social history and asking questions in an appropriate way. And once you understand the history, you can work to avoid those known triggers based on that person's experiences. And obviously, a lot of these approaches overlap, but I'll take another moment here to reiterate that you can't always rely on the person's ability to communicate and express what's triggering them or what those triggers might be. So you have to be a detective. For example, most often a person will say that everything's fine because it's the social norm when they're coming into your office. And it's really up to you to create a safe space to try to identify, what's really going on and what their preferences are and needs, unmet needs. So I think the next slide is our sources. You'll get that. And then next slide again. Thank you guys all so much for your time and attention. Jennifer and I are really looking forward to having some time to answer your questions and hear your thoughts. This is my direct contact information. And with that, let's turn it back over to our hosts.
I would just add that, as I said in the beginning, we had the right people for this webinar. I think we can all agree that that's the case. I am stunned and moved and thankful and wow. Abby, I will thank you all later. But Abby, do we have some questions?
Yes, we have a ton of questions.
I thought you might.
I'm going to try to get to them. Also, as a reminder, everyone is getting a copy of the PowerPoint as well as a recording of the webinar itself, and we will be sending additional resources as well as our presenters' information for the contact info.
And Abby, we, if possible, if you wanted to send us any questions that we don't get to, Jennifer and I are totally willing to answer questions, by email, if we have that ability. I don't know.
That is great because we have a lot. So thank you everyone for the questions. I am going to go first during Jennifer's presentation.
Sure.
I see one that says, is it okay to suggest to a caregiver that a parent is having issues with water in general, that it could be a bad experience from World War II that is causing this fear? Suggest that it could be PTSD.
I think it's always really like, however you are educating yourself, it's kind of like a parallel process. It's like whatever you are educating yourself about when it comes to dementia care, you're also going to be educating the family members. You're going to be educating the caregiver, and just sometimes it's about how they can support their loved one. So if this is something that you are learning about, it's really great to educate the family, because they may not have that insight that you have. And if it's a way for them to be able to better understand their loved one and better understand how to support their loved one, like that can only help the loved one in all in all. So yeah, absolutely.
Great. So we are going to go through all of the questions for Jennifer's presentation first, and then we will go to Andrea's. So Jennifer, we have another one. It says, how does sundowners impact patients and those experiencing aging issues?
So sundowning is it's kind of like a cluster of behaviors of symptoms that someone with dementia may be experiencing. I'm having a little hard time understanding the question, but I think so. So basically, it's something that occurs in the evening. I think sometimes we're still trying to figure out if it's because it's affecting that circadian rhythm, that biological clock, where someone really starts to feel more disoriented and confused as the nighttime is going down, because they may be having a different experience than it being evening time. So it kind of leads to this disorientation and agitation, because sometimes people aren't able to communicate what it is they're feeling and thinking. So it comes out in behaviors.
Great, thank you. So
Yeah.
This is one. How and/or if can you differentiate real memories and experiences from hallucinations with no connection to real life?
That's a good question. I mean, I think that, I think when it comes to real life experiences or hallucinations or delusions, we don't necessarily have to be a detective in that moment, because I think it's so important that we're a detective when we're trying to figure out, what the source of distress is. But if it's more the experience that's the distress, then I think it's more about just figuring out how to connect with the person and help them feel safe than trying to figure out, is this true? Is this not true? What really happened? What didn't happen? Because that then is really only to answer our own questions versus trying to provide that support in the moment for the individual. So I would recommend maybe kind of putting that aside and thinking more, what's going to help this person feel safe, and what can I do to help them feel safe?
Great, thank you. And the next question is regarding PTSD and the rates of women versus men. The question is, could it also be that women are more likely to seek treatment and therefore receive a diagnosis?
That certainly is possible, as to what some of the reasons are. I mean, there is a lot of research that has shown that sexual assault does more often lead to PTSD, and that women, unfortunately, experience sexual assault more often. So I think that's where they came up with that conclusion in the material that I was reading, but absolutely. I mean, and also, they found too that women tend to blame themselves more often when there is a sexual assault, and that can make people more vulnerable to PTSD if they can't figure out an answer and they just keep blaming themselves.
Great, thank you. And now I have a question. It says, can EMDR done pre-aging change the way these memories come out in older adults?
Yeah, so EMDR, I am not an expert on EMDR, but I have recently read some literature that says that there can be some safety in using that technique with older adults who have dementia. But as I said, I am not an expert on that. And I feel like there's a whole lot more literature that needs to be out there and research done to definitively say that it's safe for people who have dementia.
Great. And then how would informal caregivers of the elderly detect dementia signs and symptoms in their care recipients?
So it can, so that's the thing is like dementia, it all depends on the type of dementia, it depends on the individual. It's not so much of like a one-stop shop, but there are different kinds of symptoms that can alert you to receiving more like additional support and maybe some, medical help. If people, as I was mentioning before, people have memory loss, sometimes disorientation and confusion can be the next symptom. That's the thing is like people who have Alzheimer's disease, even though their hippocampus is being affected and they're experiencing memory loss, they may be, their cognitive abilities may not be affected at that point. So they're learning how to navigate around the memory loss, and other parts of the brain start to go into hyperdrive. But unfortunately, those are parts of the brain that are going to be affected next. So, sometimes it could be social lack of social inhibition, so it depends on what kind it is, but, paranoia, hallucinations, delusions, behavior changes, mood changes, as I said, disorientation, confusions, if people start to experience wandering, like if someone is going to their typical grocery store and then all of a sudden they have no idea where they are, how they got there, that is alerting. So there are lots of different things that can lead to concern. But I'd say as soon as you are concerned about someone's safety, then, you need to go and receive medical help.
All right, great. So now we are going to switch gears to Andrea. So Andrea, how would informal caregivers of the elderly dementia and signs and symptoms in their care? Excuse me, I think that was on there twice. My apologies. Let me look for one more question. So for Andrea, the methods you were talking about in your presentation, can these same methods be presented to be applied with children with special mental health issues?
That's a good question. I feel like, if we go back to that universal precaution, it's a very thoughtful and considerate approach in assessing and caring for people. I just have to say, and for those of you who specialize in older adults and people with cognitive impairment, we're always very careful not to equate this population with children because it's totally different. It can be triggering for a person to be infantilized. I know that's not what you're doing in your question, but it's a really good opportunity just for us to talk about that really quickly. People with dementia, have a whole life of accomplishments, experiences, emotions, and we really need to honor that in our work. But applying this person-centered trauma-informed care is not unique to older adults, certainly not unique to people with dementia or people with trauma, and it is very much encouraged. I'm sure there's even studies applying this approach in various populations. You've perked my interest. I'm going to look it up.
Thank you so much. So if someone knows they have a history of trauma, are there things they can do to prepare for their senior years? And along with this, asks if if a family member knows that another family member is in the situation with a history of trauma, are there things that they can do to prepare and or protect the family member before dementia or old age?
I think this is really well qualified for Jennifer, but Jennifer mentioned specifically about like untreated trauma impacting and then no longer being an option to treat once dementia has developed. And so there's a lot to that. Jennifer, do you want to jump in on that one?
Yeah, when it comes to how the brain is affected by trauma and chronic stress, if we're talking about a child who's gone through trauma, it's amazing how the brain and the body of a child can regenerate unlike it can as an adult. So, I think like if we're talking about a child, then it's really great for that person to receive treatment as soon as possible when they have experienced a trauma. When it's an older adult or an adult, unfortunately, there isn't any confirmed information out there that says if you experience a trauma and then you get help for that trauma when you're an adult, that that'll regenerate anything in the brain. There's nothing out there that shows that yet, unfortunately. So I think it's just more so being aware that this is how trauma can affect the body and the brain, and how can I better care for myself in general moving forward, because there are lots of things that you can do to reduce the chances, when it comes to substance use, cutting that back, that can really help. Smoking, eating the right kinds of foods. So just that empowerment of being aware that like I've gone through this and this is what I need to do to care for myself for my future.
Yeah, and dementia is often a result of kind of multiple factors. And so really doing what you can to make those lifestyle changes and knowing about the trauma and treating that and seeking help on that, I think is the right approach there.
Mm-hmm. Yeah.
Awesome, thank you. And then this is for Andrea. Can trauma therapy before dementia or during early dementia diagnosis help prevent the more severe trauma-related dementia symptoms that are later on during someone's dementia progression? Or is it a PTSD diagnosis unchangeably linked to the challenging dementia symptoms?
I think we kind of just covered that. But, I think that if there's anything to take away, and I admire our participants in wanting to be really proactive, I think the focus should be on the responses and having the appropriate responses, not to make it worse, and avoiding the re-traumatization. And so, maybe we need another webinar on the earlier, but we're coming at it from all of the interventions and the practical approaches once a person has obvious cognitive decline and it's interfering with their daily life and their emotional well-being.
Great, thank you. Another question is, Andrea, do you have tips for talking to your loved one's doctor or other healthcare providers about trauma?
Yes. So there's general tips, and I work with families a lot. They feel like they aren't comfortable talking with the doctor without their person present. And I want to first say it's very important for family members to maybe write like a quick summary on like what the concerns are and open that line of communication with the provider. The provider can only return the communication if there's, an agreement, authorization, HIPAA, release from the person, but that doesn't prevent the family member or anyone else communicating with the doctor about their concerns. And the way you do that is, making sure that the doctor has all the information that they need to be able to effectively treat and care for the person with dementia. And they might not know about really important elements. And so it depends on the situation, but it would be important to talk about A, the trauma, and then B, how it manifests in your loved one or your patient, in a practical way.
Great, thank you. We do have a few more questions. Again, if we do not get to your question, please feel free to email either of the presenters. We will pass on their contact information. But right now, the question is, does the person have to experience memory loss in order for them to be diagnosed with dementia?
Definitely not. I've had a number of clients who, can get a 29 or 28 out of 30 on the MOCA screening. And then somebody calls them out of the blue and says, I'm your long lost relative. Hurry, give me $25,000 or else your life is going to be over, and they do it. So there's much more to cognition than just memory.
And also there are certain types of like vascular dementia, people's memory will remain intact for a pretty long period of time if the brain hasn't been incredibly damaged by a stroke. So some types of dementia, there isn't a lot of memory loss.
Great, thank you. I'm going to do one more question here. We've gotten it a few times. It is talking about diet and exercising. Does the role of nutrition and exercise proactively and ongoing help prevent dementia? And that research is showing the impact of the above on brain health.
Do you want to jump in on that one, Jennifer?
Can you say it again? I'm sorry,
Yeah.
I was reading another question that just came up. Sorry.
No, my apologies. They are asking about the diet and dementia and diet and exercise, excuse me, and proactively helping dementia patients. Is that something that can be a possibility?
Yeah, I mean, I think there's, like omega-3 fats and certain vitamins are really good for people to take. And when it comes to exercise is supposed to be really helpful because like something with like insulin levels that can be affected when you're exercising, that can help to reduce certain progressions of the disease. So certainly, yeah, exercise and diet is really helpful.
There's a study here in our area. What is it? PMRI. I'm trying to remember. I can send it out to everybody, but they did a study about a vegan diet and a certain amount of exercise, like a pretty well-controlled study. And the findings, I mean, preliminarily are pretty astounding, and they're, hopeful for like reversal of disease process, not even just to slow it down. But when I presented to a lot of my clients a vegan diet, I'd rather have dementia. But, all we do is put the information out there and let people make their own choices and relative to their own, quality of life. I think that's important.
Abby,
Great.
I think that was our last question. At
Yes,
least
that
the
is
last
the
one that we could get to. Anyway.
That is the last one we could get to. We are going to go to the next slide. These are the call to actions.
Abby, go for it.
Oh, absolutely. So the call to actions are to visit our website, agingandtrauma.org, strategize how you will make your office and service more PCTI, so person-centered trauma informed, participate in our webinars on PCTI care. So thank you everyone for coming. And if you have questions, please contact aging@jewishfederations.org. Again, everyone is going to be receiving a copy of this presentation as well as a link to the webinar itself. And then for our cohorts who need to see this webinar, the secret word is dementia. So if you guys can write that down for when you get the survey, the secret word is dementia.
And you got one more slide there, right?
Yep, one more.
And that is our thank you slide. And I don't even know how to thank our presenters enough. What an amazing, astonishing, outstanding webinar. Thank you so much for the time, for the energy, for the commitment, for all that you do, for all that you did today. Thank you to our participants for all the work you do. It is amazing. We know that. So thank you for all of that. Keep in touch with us. You saw our resources. We will be in touch with additional webinars. So look for us, keep on touch. look for our website. And thank you all again. Have a great afternoon. And Andrea and Jennifer, wow, I got. Thank you all. Everybody take
Thank
care.
you guys so much for coming.
Yeah, thank you.